I'm Dr. Troy Smurawa, and today's presentation is going to be on overuse injuries in youth athletes. So when we look at the pediatric athlete, there are certain concerns we have about the pediatric athlete as compared to an adult athlete. And here's a table that kind of goes over a few of those points that we want to look at. So we categorize risk factors for overuse injuries. We look at intrinsic risk factors, such as growth-related factors. And there in kids, we see that there's a susceptibility of growth cartilage repetitive stress. And then also when adolescents go through their growth spurt, they can oftentimes be at a higher risk of injury. And then with other things, if they had a previous injury, their level of conditioning, other anatomical factors can also contribute into a risk of injuries in adolescents and young kids. Also in females, menstrual dysfunction or menstrual irregularities can also contribute to factors that can predispose them to injuries. Some of the intrinsic factors that we look at are things like their training and workload. And we know that in the young athlete that they may not be able to tolerate the rate, intensity, and progression of athletic training that an adult would. Also looking at the schedules that they are adhering to. So a lot of kids are maybe involved in multiple sports and multiple teams with multiple schedules. And that's something to pay attention to because that could actually lead them to a risk of injuries. Also, the other things we look at extrinsically are their equipment, their footwear, the environment they're playing on, and also the sports technique. And one of the things not to neglect is the psychological factors that come into play. And obviously, the different psychology of an adolescent young adult is different than that in an older adult. So those are some of the things that you want to pay attention to, and oftentimes can contribute to risk factors for overuse injuries in the youth population. When we look at overuse injuries, we can categorize them in certain grades. And this is a general grading system for overuse injuries. And it's not just applied to the youth athlete, but it's applied to all athletes, including adults. And this is just one adaptation of a graded scale of overuse injuries. And we start with grade 1, which is basically symptoms that occur at the end of activity or at the initiation of activity, then diminish right away. As they continue to have more symptoms, they progress to a grade 2 type of overuse injury where the symptoms develop during the activity, late onset, but then they diminish after activity is completed. Then as we continue to experience more and more symptoms of a overuse injury, a grade 3 type of overuse injury is that the symptoms do develop during activity, but now they're earlier onset and persist during the remainder of activity, but they also diminish after activity has ended. A more significant grade 4 type of overuse injury has those symptoms that develop during activity and limit the ability to train and both in frequency, intensity, and duration, and also that the symptoms will continue after activity has ended. And actually a grade 5 overuse injury is those where the symptoms prevent training are pretty much there persistently, even when they're not training. When we look at pediatric bone development, the important thing to understand is that children have growing bones, and those growing bones go through different stages of skeletal growth. And during each stage of skeletal growth, they may be more predisposed to an injury. And we talk about bone development, we look at the different types of structures in the bone development. So we can see in the upper left-hand corner here, as the bone goes more from a cartilage type of a structure, it starts to ossify or become bone as those chondrocytes develop, and then it becomes more of a typical structure of a bone. And then we have on the ends the cartilaginous portion of it, or the secondary ossification center. And the secondary ossification center has both the end of the bone where it's growing and developing, but also we have an epiphyseal plate or the growth plate. And that's where the growth plate helps with the bone lengthening. And that's where the kids oftentimes will have susceptibility to an injury as they're growing and developing. We can see on the right side here, again, a more schematic picture of the secondary ossification in the part of the bone we call the epiphysis, and then the growth plate we call the physis, and then the adjacent to that is called the metaphysis, and then we have the long bones. And at the end of the bones, we also have the articular cartilage. And one thing to note is that in kids' bones in their joints, the articular cartilage is very thick and prominent. And as they get older into adults, that articular cartilage thins out and becomes more susceptible to injuries. So when we talk about the growth cartilage, I mentioned before that the growth cartilage are three different areas. We look at the articular surfaces of the bones, and that's where the articular surfaces are in the joints. And that articular cartilage you can see right here is very thick and very vibrant in a young, healthy child. As they become more of an adult, that thins out and become more susceptible to injury. Then we look at the physis, and this is the epiphyseal plate or the physis, and that's there from infancy to adult height when it's achieved. And that's where the bones are developing and growing and lengthening the bones. And then we also have what are called apophyses. And apophyses are at the ends of bones, and that's where tendons attach to. And these types of structures develop at certain ages, and there's a certain group develop at ages somewhere between the ages of 8 to 12, and some 12 to 14, and others 12 to 16. And during that period of growth, the bone becomes more ossified and eventually connects with the main bone. And that's a period of vulnerability where that growth plate can become injured. And we'll talk more about specific entities associated with inflammation and pain of those growth centers. So we look at an anatomy of the bones on a radiographic picture. We can see that if we're looking at the knee from the front to back view, this is what we call the physis or the growth plate. The area closest to the joint is called the epiphysis. And then over here on the lateral view, you can see the physis, the epiphysis, and this little structure, which is a extension of bone growth called an apophysis. And that's where tendons attach to. And oftentimes they can have inflammation of these apophyses, which may lead to pain and inflammation. So when we talk about growth plate injuries, oftentimes growth plate injuries are a result of repetitive or an acute stress applied to the growth cartilage. We typically call the growth plate the weakest link in the bony structure. So when someone gets stressed, more often it's the growth plate that gets injured than the bone or the ligaments. And that's something to be aware of, and especially in kids when they're growing, developing, and to understand that if they have an open growth plate, a very developing growth plate, that's more likely the source of injury than the adjacent structures or ligaments around that growth center. So some of the pearls about growth plate injuries is to know that ligaments in children are functionally stronger than the bone or the growth plate. Therefore, children are more likely to sustain fractures rather than sprains. So if a child is tender over her or his physis, but the x-rays appear negative for a fracture, we should treat it as a potential growth plate injury and may have to splint and have that child follow up with a sports medicine physician or orthopedist to further evaluate and assess the injury to that growth plate and the possible progressive healing or injuries that could further occur because we don't allow that athlete to rest and prevent them from participating in sports. So I talked about apophyses. Apophyses are these little growth centers that are at the ends of bone. Where growth plates, they are with the length of the bone. Apophyses add shape and contour rather than length. Oftentimes, they're at the sites of muscles and tendons attachment. And with that, avulsions at the apophysis are not uncommon in older children and adolescents. As the force of the tendon applies to that growth center, they're oftentimes able to cause irritation or inflammation of that growth center and sometimes a separation. And typically we can assess the nature of the growth center by x-rays. And typically these respond well to conservative management and very rarely require any type of surgical intervention. Now, avulsion fractures are acute injuries that occur at the site of the attachment of the tendon or the muscle to the growth center. And again, these are very common at the site of apophyses or where the growth is developing in the bone. And at certain ages, certain growth centers are more active and more developing and more susceptible. And we can see here in the pelvic bone of an adolescent, down here where the hamstring tendons attach to the apophysis, there is an acute avulsion. You can see the pulling away of this bone and a reaction of that bone to that. And that what we call an acute avulsion. Most avulsions are mild and can heal on their own, but sometimes some of those may require surgical intervention. Chronic injuries are the most common thing we see that involves growth centers and growth plates. and structures in children. And oftentimes the presentation is a gradual onset of pain. They may oftentimes have a recent increase in activity that can attribute to their increase in pain. So oftentimes at the beginning of a season, whether to start a new sport or start an activity, as they jump into that new sport, they may go in from participating with minimal amount of time during a week to participating 4 to 5 times, up to 7 times a week during that season of that sport. What they may notice is they may first may notice some pain, but then as it progresses, they'll notice some weakness, poor performance. And if there is involvement of the lower extremity growth center, they may oftentimes prevent with a chronic limp. Oftentimes, we'll see that this will follow growth spurt. So if a child is going through a growth spurt, that's an opportune time for that growth center to be more susceptible to injuries, whether it's acute injury or chronic injury. So you always want to be very suspicious of growth plate injuries or apophyseal injuries in a skeletally immature child or adolescent if they present with chronic type of pain or an injury. When we look at the chronic injuries or growth plate injuries, what they're going to have is localized tenderness over that growth plate or that growth center. And the pain or weakness will occur when they're testing the muscle attached to that site or the apophysis. So if they have inflammation or an injury to the ischiotuberosity apophysis where the hamstring attaches to, they may have a tight hamstring, pain with resistant hamstring manual muscle testing, and also may have pain when stretching the hamstring tendon. And as I mentioned, if it's involved in the lower extremity, they oftentimes present with an altered gait or a limp. It may be very subtle. It may be something that come on gradually and get worse over time. It may actually only occur after activity, and by the next day, that limp may go away and they're doing well until they start to participate in sports or activities again. So when we talk about chronic injuries, we talk about apophysitis. There's some specific apophysitis that we see very commonly in children and adolescents. And there are also stress or growth or overuse injuries that occur to the shoulder or the back or other structures that involve the epiphysis, or we call the growth plate. And we'll talk about these in detail, but the common ones that involve apophyses are the Osgood-Schlatters apophysitis around the knee, Seaver's apophysitis, which involves the heel, Syndig-Larsen-Johansson apophysitis, which involves the bottom of the kneecap, and a pelvic apophysitis that involves different growth centers around the pelvic bone. And then physial stress injuries or fractures can involve the proximal portion of the humerus, and that's called little league shoulder. It can also involve the elbow. And also we see that they can have inflammation around the back, and that can cause a unique injury in adolescents called spondylolysis. So in general, when you analyze a young athlete or adolescent and determine that they may have a significant injury that may involve the bone or growth center, it's very important to recommend them and refer them to a sports medicine or orthopedic specialist, because sometimes you may not be completely accurate with the diagnosis. So if the diagnosis is uncertain, they can help in better ascertaining that injury and determine whether it involves a growth plate or not. Also, some of these growth plate injuries and musculoskeletal injuries are at a high risk for further injury or long-term problems. So it's very important that if there isn't concern about a high-risk condition or injury, that they get referred to a sports medicine or orthopedic specialist. And also, if it's a simple injury, but it seems to fail conservative management of rest, exercises, ice, anti-inflammatory medicines, then that's a good reason to refer them to a specialist, because that could indicate that there may be something more underlying to their injury rather than the simple injury that we typically see, and they can further evaluate and assess and see if there's something more serious involved or more significant involved in that injury. Prevention. So prevention is a key part of helping kids participate in sports without pain. So one of the key things is that during a pre-participation physical examination, that there's a careful examination of the musculoskeletal system to understand if there is any underlying conditions of tightness, weakness, problems with any type of growth plates presenting with, and that way you can address it early on and prevent those things from possibly happening. Also, a part of prevention is proper supervision and coaching with youth athletes. It's important that coaches that involve youth athletes understand that there are unique characteristics of the pediatric musculoskeletal system that may make them more prone to injuries, especially overuse injuries. So making sure that they're understanding how these present and when to rest that athlete and have them seen by a medical professional if they present with some type of injury. Also, it's important to identify and correct any biomechanical flaws, whether it's your pitching mechanics or running mechanics, jumping, landing. All those different things can contribute to stress and injury to the growth centers and the structures of the musculoskeletal system of a young athlete. We also want to encourage strength and flexibility early on, not too much strengthening, but enough that is appropriate to their age and ability level. But improving strength improves stability and improves the stamina of those joints and musculoskeletal systems and allows them to prevent them from overworking them and getting injuries. One of the things that we always talk about is sports specialization. And sports specialization refers to an athlete focusing on one sport year round and really trying to make them better at that sport. And we know that sports specialization at a young age can predispose them to repetitive injuries and overuse injuries involving certain structures depending upon the sport they're in. So it's important that kids don't really focus on sports specialization early, but really focus on experiencing other sports, making sure that they're really using all avenues of their body, experiencing sports that kind of develop a well-rounded type of an athlete rather than someone that specializes in one sport. Also, it's very important that they have periods of rest after sports season. It doesn't have to be complete rest, but at least a rest from that sport and more of an active rest. And that rest period can be used for active recovery and rehabilitation from any injuries. It can also focus on off-season strengthening and training and conditioning. And we also talk about gradual increase in volume intensity at the beginning of the season, also when they're recovering from an injury. That's important to really progress them back into their sport and activity and not jump 100% back into it after they've been out of time from an injury. I think the most important thing is to not let kids play through pain, because pain is an indicator of injury. And if a child is experiencing pain, that usually means that they're having some type of structural injury to the musculoskeletal system, and that needs to be carefully evaluated and giving them specific guidelines on how to rest and recover and rehabilitate and then progress back to activity because of that initial injury to the musculoskeletal system. So I'm going to talk about some specific injuries that occur in the growth plates around young athletes, and we'll talk about them in specific and in general, and about mechanisms that can occur, things that you have to look out for, and things that we can do to help treat them when they do occur. So when we talk about the pelvis is a large bone where multiple muscles and tendons attached to. And typically when kids are usually around the ages of 12 to 16, and when these growth centers are starting to develop and are active growing. And what we look at is the apophyses around the hips where the muscles and the tendons attached to. And sometimes it can have an injury, which is a sudden contraction of muscle that causes an acute injury or acute avulsion of that muscle tendon growth plate attachment. And oftentimes they'll present with an acute pain. And sometimes they'll say, I heard a pop or something pull, and I was walking, running, doing fine, and now I can barely walk, or it hurts a lot to activate that muscle. And that's something to pay attention to, and that's something to really get them evaluated. Activities where this typically occur are activities that involve sprinting, hurdling, kicking, jumping, and performing the splits. During these activities, there's an acute contraction of the muscle and actually acute pull on that growth center, and that can result in an acute avulsion of that growth center. They'll typically, the symptoms they present with is a sudden onset of tenderness and pain at the apophysis. They may have swelling depending upon where it's located. They'll also have pain with stretching the involved muscle and also activating that muscle. And they'll show weakness and pain when actively contracting the involved muscle that attaches that apophysis. And that's something important to know, because they should not push through it if they have that, but really it's important to get them treated and allow that to heal so it doesn't cause a more prominent or more debilitating injury, and that may take longer to get better. So this is kind of a schematic of the pelvic apophyses, and we can see on top of the pelvic bone is what we call the iliac crest, and there's a growth center up there. In the front of the pelvic bone, there's a little spine here and a spine there. That's basically, a spine is a projection of the bone. And there's two ones that are called the anterior superior and anterior inferior iliac spine. And those are where muscles of the hip flexor are attached to. And those are oftentimes injured when running, jumping, and kicking, especially sports that involve those type of things like soccer, gymnastics, even sports that involve a rotation of the hip like ballet can cause injuries to that. There's other ones, the greater and lesser trochanter, the ischial tuberosity where the hamstring attaches to, and then obviously this is the half of the pubic bone, but the other half attaches to that, and sometimes you can get an injury to the muscles attaching to this part of the pelvic bone. And here's another schematic of, you can see the different type of muscles and where they attach to: the hamstring muscles, the iliopsoas, hip flexor, the gluteus minimus muscle, the gluteus maximus muscle. The sartorius attaches up here to the anterior superior iliac spine. The rectus femoris attaches to the anterior inferior iliac spine, and the abdominal muscles and the lateral hip muscles attached to the iliac crest up here. And this is just, again, another schematic on the x-ray of where those different types of attachments occur. So here is just another x-ray imaging of a iliac or a pelvic apophyseal avulsion. Here we can see the ischial tuberosity avulsion. You can compare it to the left side, which is nice and smooth, and here you see more of a pulling off. And this is actually has been there for a while, and there's actually some chronic pulling of that. Here is the anterior superior iliac spine where the rectus femoris attaches to, and you can see a pulling off of that little avulsion growth center. So typical treatment for iliac crest or pelvic apophyses are basically you want to rest them until pain-free. And oftentimes that may involve crutches with partial weight bearing to non-weight bearing to the point where they can actually weight bear without pain. Rehabilitation first focuses on stretching and gentle stretching. And then once they are able to have full function of activities of daily living, they can start to gradually return to the function with minimizing the activity that involves the explosiveness or pulling out of that muscle where that tendon attaches to. Apophyses can take up to 1 to 2 months to get better, and even an avulsion fracture can take even 3 months to heal before they get back to full activity. The important things to know: if you're impatient and allow that athlete return too soon, then they have a higher risk of that recurring. And if that happens and they re-avulse that growth center, then they have to start the whole process over. And now, if they're going back too soon, then they're going to have to go back to ground zero and start that symptom and process all over. So really be cautious and err on the side of conservatism and give them a pretty good length of time to recover before they return back to that sport. So iliac crest apophysitis is a little bit different than the avulsion. An avulsion usually is an acute injury. The iliac crest apophysitis involves the top of the pelvic bone, and this usually is a stress injury to the apophysis. It's not something that occurs acutely. Most of the time it occurs over time. They can get tiny avulsion fractures from repetitive microtrauma from the muscles and tendons pulling affid, but sometimes it can lead to acute fracture or acute avulsion on top of that chronic injury. It's most often seen in distant running, dancing, and other sports that lend themselves to training repetition and impact activities. And here you can see the growth center on the left side compared to the right, where there's actually a widening or separation of that growth center. So it's often found in the immature runner who does not have correct or strong running form, and they'll have more stress on those growth centers as the abdominal muscle, the lateral hip muscles continue to pull on that and irritate it. And oftentimes we'll see runners that actually cross their arms with running, and that puts that stress on it. So it's important to understand the nature of this injury, and that running can create that type of a stress, and that when they get back to running, that they also correct the running mechanics in addition to allowing that bone to heal. Typically in exam, you reproduce pain with resisted hip abduction. They'll also have bony tendons localized over that iliac crest. And the x-ray can look normal, but oftentimes you'll see widening of that iliac crest, and it's very subtle, and oftentimes you won't recognize it unless you compare it to the non-symptomatic or non-injured side. So typical treatment, this is self-limited relative rest. That means resting them and removing that activity or that sport or running that irritates it. Focus on flexibility and core strengthening, working on and giving them the opportunity to strengthen the muscles around that muscle that's injured. And then oftentimes over-the-counter medicines and anti-inflammatories and ice will help with pain and inflammation. Then as they progress back into activity, you want to make sure they have adequate footwear that minimizes stress when they're running. And also, again, looking at the running mechanics and making sure that there aren't any issues with the running mechanics and correcting them as indicated. So patellar tendonitis or jumper's knee is very similar to what we call Osgood-Schlatt's, we talk about next. But this is more inflammation of the patellar tendon at the inferior pole of the pole to the tibiotubercle. And this involves the main tendon itself. Again, it's an overuse repetitive injury that involves quadricep contraction in sports that involve jumping, running, and sprinting. So sports like running, basketball, volleyball, track and field oftentimes will put stress on the patellar tendon. They'll present with anterior knee pain with loading of the patellofemoral joint. Oftentimes jumping will be painful. You may notice some mild swelling, tenderness over the patellar tendon, and you'll oftentimes will palpate some crepitance or crunching feeling and swelling in the infrapatellar bursa area, and they will have pain with resisted knee extension. Here is a diagram. You can see the patella here, the patellar tendon as it goes from the bottom of the kneecap to the tibiotubercle, and this is the area where the patellar tendon can oftentimes get inflamed. To treat patellar tendonitis, we really work on ice massage before and after activity, anti-inflammatory medications in the beginning to treat the inflammation. Then really to improve it, we work on muscle exercise that involves the VMO and the quadricep muscle. We work on quadricep and hamstring stretching, and oftentimes a patellar tendon band or sleeve will help minimize the stress on the patellar tendon. And return to activity is gradual and as tolerated, but you want to avoid jumping and running initially until they are able to tolerate that type of activity and gradually progress to that activity. Now, Osgood-Schlatt's is involving that extensor mechanism of the knee, and it is a traction hypothesis of a tibiotubercle. And whereas patellar tendonitis involves the main body of the patellar tendon, this is the attachment of patellar tendon in the tibiotubercle at the proximal tibial bone or the shin bone. This typically presents in ages 8 to 13. There may be some predisposition genetically to this, so it tends to run in families with it. The mechanism of overuse is often repetitive microtrauma from running, jumping, and kicking type of sports. So sports that involve running and jumping, such as basketball, track, volleyball, soccer, can contribute to developing of this condition. Typically, people with Osgood-Schlatt's will present with an enlarged and painful tenderness over the tibiotubercle. Sometimes they will have swelling due to the inflammation of the soft tissue overlying the tibiotubercle. The pain will be increased with running and jumping activities. Diagnosis is pretty straightforward. They'll have localized swelling and point tenderness of the tibiotubercle. X-rays are not necessary in every case, but only if there's an atypical presentation or if they're unresponsive to conservative treatment, you want to rule out fracture or fragmentation of that tibiotubercle apophysis. So here is an X-ray schematic of Osgood-Schlatt's. You can see the normal little tibiotubercle growth center here, and now you can see some soft tissue swelling anteriorly and a little reaction to that irritation, a little calcification in the distal tibia that's a result of chronic Osgood-Schlatt's inflammation and apophysitis. Typical treatment is applying rest, ice, compression, elevation, and oftentimes anti-inflammatory medicines help with the inflammation and swelling. Rest is relative and restricting jumping activities as they need to. Some athletes need to completely rest. Some people can minimize the amount of jumping activities and activities they do. We often find that an Osgood-Schlatt's sleeve or patellar tendon strap that they can use can help reduce the inflammation and pain on that growth center. Return activity is as tolerated. It may take up to 3 to 6 weeks and some people to return, but it's really self-limiting. It's really at this point pain tolerant based upon the athlete. So if they can tolerate some pain, it's okay for them to participate. If they're having a significant increase in pain, they probably need to rest it for a period of time. Now, Syndig-Larsen-Johansson syndrome also involves that extensor mechanism of the patellar tendon, whereas Osgood-Schlatt's is at the distal attachment of the patellar tendon into the tibial bone. Syndig-Larsen-Johansson syndrome involves the proximal insertion of the patellar tendon in the bottom of the kneecap. And this happens a little bit earlier than Osgood-Schlatter's. It happens again, usually about the ages of 13 years old, but a little bit younger. Again, the same mechanism: overuse, repetitive running, jumping, injury, same sports, running, basketball, volleyball, and track is where we typically see this happen. Symptoms are usually gradual onset of anterior knee pain that's usually localized at the bottom of the kneecap. It is usually increased by running or jumping activities. Again, diagnosis is point tenderness over the inferior polar patella with pain resistant knee extension. Pretty classical findings, pretty obvious findings on examination. If you did x-rays, you may see a normal x-rays, or you may actually see elongation of the inferior polar patella with irritation, inflammation, and chronic changes in that little growth center at the bottom of the kneecap. Here you can kind of see a little thin line of the little growth center right here at the bottom of the kneecap. And here you start to see a reactive elongation of that growth center because of chronicity of Cinder Larsen-Johansson irritation of that little apophysis. Treatment is pretty similar to Osgood-Schlatter's. You want to apply rice, ice, compression, elevation, anti-inflammatory medicine help with pain and inflammation. Again, you want to restrict activities until symptom-free. In some very severe cases, we may cast the knee for 3 weeks to reduce the inflammation and pain in that growth center. It's not absolutely necessary, but sometimes that is found to really significantly reduce the pain and inflammation. Usually they will have healing in 6 to 8 weeks after onset. It may not take that long before they get back to playing. Usually you can get back to activity when pain-free, and that may take 3 to 6 weeks to occur. And again, we tell athletes and parents that this may kind of recur as they're more active, but just pay attention to the pain and let pain kind of be the limitation or guideline of what they do from an activity standpoint. Now, as you move down to the foot and ankle area, there's another growth center at the heel called the calcaneus, and that is a little apophysis called the calcaneal apophysis. And when they get inflammation of this apophysis, we call it calcaneal apophysitis, or another term is Sever's condition or Sever's disease with it. The mechanism is the same thing. It's a traction apophysitis of the Achilles attachment to the bottom of the heel. And what happens is with running and jumping activities, they pull on that and it causes irritation and traction. Oftentimes, it can be associated with impact activity. So if they're in a sport where there's a lot of landing on the heel, especially on a hard court or a hard surface, that impact activity can also contribute to irritation of that growth center. It typically occurs between the ages of 8 to 13. It oftentimes is bilateral, more often in males than females, but does happen in females as well. Symptoms are usually pain in the back of the heel, worse with activity. They usually have pain walking on their heels in their bare feet. And that's a good indication and a sign that they have inflammation of that growth center. They also have pain, what we call calcaneal squeeze. If you squeeze the heel, they'll have pain at the apophysis. X-rays usually aren't necessary and not helpful in the diagnosis. They're oftentimes normal. Oftentimes we'll get X-rays if we're concerned about something else or for suspicion for avulsion, which is very rare, or if they have an acute traumatic injury to the heel where you're concerned about a fracture of the growth plate or the calcaneus itself. And here on the X-rays, you'll see the growth center with the little growth plate right here where the little arrows are, and the tendon attaches to that. And so both from pulling on it and impact from below irritates that little growth center and causes inflammation of the growth center. So treatment is pretty straightforward. Again, ice as needed, non-steroidal anti-inflammatory medicines for pain and inflammation, relative rest. The two things that help are gel heel cups, you can see here, and that cushions the heel, and Achilles tendon stretching, we can see on the left side here with the towel. And we instruct the parents and the athletes that this is important to do this on a regular basis, every day, especially in times when they're active and participating in sports. Now, Iceland's apophysitis is another little less known traction apophysitis. So the apophysis is located at the base of the fifth metatarsal on the lateral aspect of the foot. This is where the peroneal muscle and the tendon attaches to the base of the fifth. So oftentimes this occurs between the ages of 18 to 13 years of age. It's increased more likely in youth sports, and typically they'll present with pain on the lateral aspect of the foot at the base of the fifth metatarsal. It's oftentimes increased with activity. The diagnosis is localized tenderness at the base of the fifth metatarsal. Again, x-rays are helpful if we want to be evaluate for a possible avulsion fracture that occur, or if there's a traumatic acute injury. Sometimes it may have a fracture at the base of fifth metatarsal bone that does not involve the growth center. So that's important to really look at these if we're concerned about a tubercle avulsion fracture or Jones fracture, which is a little bit more distal in the metatarsal. So x-rays will help to delineate between an injury to the growth center, an injury to the tubercle, or a base of the fifth metatarsal, which is considered a Jones fracture. Here we can see just some x-rays. Here's a large apophysis. You can see a large apophysis here. This is more chronic, and there's probably a little bit more of a chronic avulsion there. Oftentimes it's just a very thin sliver, as we can see here. Treatment, again, is ice, anti-inflammatory medicines, rest, and sometimes putting a gel padding on the side of the foot may help if they're in a shoe activity where that shoe pushes on it and causes pain. And again, activity is self-limiting, play is tolerated, rest is needed for pain. So that kind of goes over all of the common youth injuries that we see, typically unique to the youth athlete. There's a lot more injuries that can occur, but these are very common ones that we typically see in a very active young sports medicine practice. And an important thing is to recognize that these are common, how to treat these and diagnose these, and also to understand if there are any risk factors that may predispose of some underlying long-term issue, if it's not an obvious overuse injury to the growth center, or if there's something that needs to be further evaluated. It's important to get them to a sports medicine specialist or a pediatric orthopedic surgeon that is very familiar with these types of activities and that involve the growth plates of a young athlete. So with that, I mean, that concludes my talk today. If you have any questions, there'll be answering questions, I believe, on the website with specific questions and opportunities to submit questions to our facility to answer anything that may come up at that time. Thank you and have a great day.